I saw you over there.
Susie. Hey there. Good morning. How are you? No see.
I don't know anyway.
Yeah. How's work? Holding camera well. You know, you point and shoot in these kind of things. So I think I could use, yeah. Just taking notes or?
Yeah, much. Learning.
Sorry. Would you maybe want to chat after? Possibly, maybe. Think about it. That's fine.
See how it goes.
Okay, fair enough.
What are you doing? We're gonna have executive session. May want to talk.
Christina sent it.
Well, I don't know what she's gonna do. Start out with executive session. Okay, so we're gonna have.
Yes, if she's available. Great. Should I just swing by her office? Video as well. Yeah, a little cramped in here. But yeah, great. I will see you afterwards. Thanks so much.
Committee on Children and Families will now come to order. Secretary, call roll.
Franklin, Chair. Vice Chair, Neely.
Here.
Beard. Bratton. Brown. Gannon. Here. Haefner. Here. Lauer. Here. Meredith. Newman. Knorr.
Here.
Brimley.
Putting it in outwards. We're just going to be doing
Appears we do not have a quorum, so we're going to go ahead and open up as a subcommittee. And we'll now hear House Bill 190 by Representative Swan. And we, if the sponsor would like, we can move right on afterwards into House Bill 427, and then we could have a discussion for or against and for informational purposes. Representative Swan, you have the floor.
Thank you, Mr. Chair. I certainly do appreciate the opportunity. My name is Kathy Swan, District 147 from Cape Girardeau, and appreciate the opportunity to present information regarding these two bills today. The first one up is House Bill 190. This is a quality health care bill. You may recall from last session, I had this bill, at least this bill is a piece of the other bill that was filed last session, of which there were 107 that it remains that was on the other bill from last session is what I will be addressing. And this bill, as indicated, is a Women's Healthcare Protection Act, and it does exactly just that. It protects women. Early the previous year, the Missouri Department of Health and Senior Services detailed 14 pages of safety violations at the Planned Parenthood facility on Forest Park Avenue in St. Louis, to include violations of infection prevention protocol, rusty surgical tables, suction abortion machines, IV stands, and other equipment, copious amounts of dust in surgical suites and on equipment, retain leftover single-use drugs that were to be destroyed after that single use, expired drugs, expired postpartum balloons, lack of appropriate drug handling policies, and hiring personnel without performing a mandated search of the employee disqualification list. During the 4 years from 2009 to 2013, at least 23 ambulances were called to the facility, and 9 were dispatched after the January 2013 violation was issued. These emergencies occurred after inspections showed that the clinic and personnel risks were to have been corrected. In 2004 to 2008, there were no inspections. In 2009, there were 2 inspections, of which the items were corrected. In 2010 to 2012, there were no inspections. In 2013, there were 2 inspections and the items were corrected. And there were, in January 21st of 2014, no deficiencies were cited. Currently, annual on-site inspections are not required for ambulatory surgical centers. So therefore, as this bill states, ambulatory surgical centers operating for the purpose of performing or inducing any second or third trimester abortion or 5 or more first trimester abortions per month, the Department of Health and Senior Services shall make an on-site inspection and investigation at least on an annual basis. In addition, the inspection and investigation reports shall be made available to the public, and regardless of the medical procedure, all patients are entitled to and should receive quality health care, the best quality health care that we as healthcare professionals can provide to them. And that is that we follow proper protocol for safety and infection control, that we ensure that the equipment is clean, that we administer current drugs, that we do not administer unexpired medications, and we use current unexpired medical supplies. This bill truly is about quality health care. Quality health care should not be dictated by a specific illness, a treatment, procedure, and certainly not by gender. Fiscal note on this bill is that there is no impact to the state or to any political subdivision. And I would be most happy to entertain questions.
Do any committee members have any questions? Representative Norm.
Thank you. You say there's no physical note?
The fiscal note says there is no state impact and no political subdivision impact.
Well, if they're not inspecting that at all, wouldn't it cost to inspect?
They have begun some of the inspections, you can see from the information that I did cite to you. In 2014, on January 21st, there were no violations that were found or no deficiencies cited. And in 2013, there were 2 inspections. So the bill requires at least 1 annual. So the numbers of inspections have been stepped up, considering from 2004 to 2008, there were none.
So without cost.
That's what the fiscal note says
Okay, thank
from
you.
oversight.
Any other questions for the bill sponsor? Yes, Representative Dillon.
To inquire, Mr. Chair.
Proceed.
Good afternoon,
Good
Representative.
afternoon.
The clock real quick. In terms of some of the information you just presented to us, the inspection that you're referring to was from what year? The initial inspection you were talking about
2004 to 2008, there were no inspections.
by the state.
Correct. And there were none from 2010 to 2012.
Well, let me go back further. For your knowledge, those inspections were not done through which department?
Department of Health.
Okay, but do you know if they were undergoing any other type of inspections during that time?
I only know about the Department of Health.
Okay, so that's what we're talking about, is just this one department
The
here.
Department of Health.
Okay, in terms of,
Yes.
but you're not aware of any other restrictions that they have to actually follow or any other inspections that they have to undergo?
Not for the purpose of this bill, no, I am not.
Okay, so you're just talking about health, just want to make sure that
Yes.
that's clear. And I'm sure we'll hear some other testimony and we'll be able to get to the bottom of that. And so tell me again what your intent is behind this.
We've had numerous ambulance calls, emergency calls to that facility, and then upon some of the earlier inspections, the breach of proper medical practice regarding infection control, pharmacology, the administration of single-use drugs that have not been eliminated and destroyed. As a nurse by education, I find that quite appalling. That was
And that information was coming through which department?
Department of Health.
Department of Health. So, but
Yes.
you're not familiar with the other, inspections that even surveys that any of the other physicians or anybody else that's there medically that has to undergo?
I have no documentation from any other entity who may have done inspections, but obviously with these violations, it would violate any particular standard medical practice.
Thank you very much. I mean, I'd like to wait and actually, get some more documentation, more information. Thank you.
Representative Meredith, proceed.
So if the Department of Health didn't do the inspections in the years stated, 2004 to 2008 and 10 to 12, when were these inspections made when they found all these violations?
There were inspections in 2009, but items have been corrected. There were 2 inspections in 2013 as well.
So in 2009,
2009.
there were inspections and they were corrected.
That is correct.
So in 2010, they weren't corrected?
There were no inspections in 2010,
No
2011,
inspections.
or
So-
2012,
How do we know there's still a problem?
because of the ambulances that continue to appear at the facility.
Do we know why those ambulances are staying at the facility? I
We
mean,
don't.
it could be anything.
We don't have detail as to why the ambulances are appearing here. But having the history of this type of practice, I don't think any of us would want to go to a medical facility, much less a surgical facility, and have any procedure performed, regardless what the procedure would be, with a facility of this history. So therefore, the annual inspection will ensure that proper protocols are being followed, which obviously reduces risk and emergency risks for patients.
How do you know about are these ambulance things? Are they, who's tracking it?
They're observed
By
bystanders who are watching the facility.
bystanders watching the facility?
Yes.
So in other words, they have no idea why those ambulances are there.
Obviously, they're there for an emergency purpose.
Well, sometimes. I mean, I live in a neighborhood with a lot of older people, and we have ambulances all the time, and sometimes they leave empty, and sometimes they leave full. Depends upon who got scared or who got hurt. So it could be any number of things. It could be somebody got there, and there was a problem that they detected and needed to send to a hospital, which is a much larger, more equipped facility. I mean, is that a possibility?
The bill is based upon data produced with the Department of Health of the documented violations of rusty equipment and expired drugs and improper procedure. It's
From
not based
2000
upon observation.
In 2009,
2009, there were 2 inspections. 2013, there were 2 inspections. The violations have been subsequently
so
abated.
the violations are taken care of,
Correct?
and we have bystanders. These like residents that live in the neighborhood that called us in? I
I'm
mean,
not basing the bill on bystanders. I'm basing the bill on the documentation from the
we
State
said the
Department.
ambulances appeared as said, as, I was asking how you knew about the ambulances, and you said that bystanders reported it, and I'm asking, who are the bystanders? Are the people staying around watching Planned Parenthood?
I think someone might be able to answer that question for you as they come to
Okay.
witness stand.
I have another question. Do we know if these ambulances, I mean, it's a building. And it has a number of different things that happen here. Well, women healthcare, for one thing. They do breast exams, they do pap smears, they do well women healthcare. And it could be something happened with one of those visitors. I mean, there's a lot of things that go on there that have absolutely nothing to do with abortions.
I agree, but we're talking rusty equipment, expired drugs. I'm not talking-
That is old, from 2009, that's 6 years ago, and they fixed it.
There were 2 inspections in 2013 with which there were violations that were found and items were corrected.
Was it rusty then too?
We can get that detail for you if you would like that. I don't have it with me.
I sure would.
And there are inconsistent inspections, obviously, through the last several years.
Are there any other committee questions from this here before we move on to House Bill 427? Representative Swan, you have the floor on House Bill 427, and the chair is back.
Before we do that, let's go ahead and call roll now and establish a quorum.
Chair Franklin. Vice Chair Neely.
Here.
Beard.
Here.
Bratton.
Here.
Brown. Gannon. Here. Haefner. Here. Lauer.
Here.
Meredith. Here. Newman.
Here.
Norn.
Here.
Brimley.
Here.
And what's the number? 11. We have a quorum. Proceed when you're ready.
Thank you, Madam Chair. Would you prefer to have witness testimony on 190 before proceeding?
Let's do after what you both
Thank you.
Uh-huh.
Moving on to House Bill 427. In addition to the women's health care quality provisions in the previous bill, as previously presented, House Bill 427 is a budget prioritization bill. And as a legislature, it is our responsibility to have a plan, place into account for every dollar, both state and federal, and to prioritize how those dollars are distributed and spent. This bill prioritizes public funds to maximize the benefit for our Missouri women. As noted in the bill, public funds include state general revenue, state special account, and limited purpose grants or loans, or both federal funds under Title V, which is Maternal and Child Health Services Block Grant under the Social Security Act. Title 19, which are grants to states for medical assistance programs, and Title 20, which are block grants to states for special services and elder justice. The main provision of the bill defines the order of priority for expenditures or grants of public funds for family planning services by the state. One would be healthcare facilities owned and operated by the state or political subdivision. Second would be non-public hospitals and federally qualified health centers. Third, rural health clinics, and 4, non-public health providers with a primary purpose of primary health care services. The goal of this bill is to prioritize the distribution of public money for the public good, distributing dollars to facilities over which we as a state have not only an interest, but a responsibility. The fiscal note on this bill is 0. Be very happy to entertain questions.
Thank you, Representative Swan. Are there questions from the committee? Seeing none. We will move in then to those in support of either 190 or 427. Are there citizens here, folks that have driven up from and not affiliated with an organization or, okay. Please proceed forward.
Good afternoon, members of the committee. My name is Joanne Schrader. I'm here in support of House Bills 190 and 427. Just to let you know, hospice facilities are inspected not less than once annually, according to revised statutes 197.258. Daycares receive 2 announced and 2 unannounced inspections annually. And I believe that women who are entering ambulatory surgical facilities, especially for abortions, deserve the same consideration. Having a mandated inspection takes it out of the realm of political whim. Right now, it's just when the department deems necessary. It is a matter of quality control and accountability. Like Representative said, the Planned Parenthood facility in St. Louis had 27 documented ambulance calls in the last 5 years, and I provided her with a list of those dates. We do not know what the purpose for the 911 call there, because that information has been blocked, although it is public information according to sunshine requests, and someone else will be able to speak about that. And it only makes sense to me regarding 427 that public funds should be directed and prioritized according to state-owned and operated facilities, rural health clinics, federally funded clinics, and then onto non-public providers. Are we under the 2-minute rule like we were last time?
No, that is so good of you. We were just discussing that, and we should have gone ahead and let you all know that we would do the 2 minutes again, because we do have a couple of department heads here who have come to visit with us, and we want to be sure that we have time to hear them today. And Mr. Decker is back for his second turn at the committee, so we certainly want to get him there at the stand. So yes, 2 minutes. Thank you.
Okay, and I also brought a copy of that inspection report from 2013 that listed the 14 pages of deficiencies.
Would you like to leave that with us then?
It's my only copy.
Okay. All right, you might get with those sponsor and see if she wants to distribute that.
Okay,
Be sure to fill out a witness form.
I have them prepared.
Thank you so much. Are there other citizens that would like to speak in favor of the two bills or either or bill? Any citizens?
We're in support.
All right, if you are in support, if you just, you'll need to fill out a witness form for us. You've got that, just bring that up and say I'm in support, and that'll suffice that. Thank you. Yes, sir.
Hi, my name is Daniel Baker. I work for Stanley Cox. I hear some of you might know him. I'm testifying in support of House Bill 427. I support both bills, but I've spoken with the bill sponsor and have been asked to say a couple words about House Bill 427. I believe that this bill is great for regulating funds pursuant to Titles 5, 19, and 20 of the Social Security Act, but I believe that an amendment should be made to also regulate federal funds provided by Title 10 of the Public Health Services Act. Representative Beard has filed two bills, House Bill 610 and 611, and I've also spoke with him about incorporating these two bills as an amendment, and I believe that these would fill in a gap of federal funds. Right now, Title 10 funds are administered through the Missouri Family Health Council, which is a private organization which administers all Title 10 funds in Missouri. This organization lists the Central West End Health Center as a Title 10 clinic. Federal law prohibits Title 10 family planning funds from being used for programs where abortion is a method of family planning. And Missouri has its own prohibitions on utilizing public funds to support abortions. The Central West End Health Center is a Title 10 clinic that shares a physical address and a website with the Planned Parenthood of the St. Louis region in Southwest Missouri, as well as Advocates, the political arm of Planned Parenthood of the St. Louis region in Southwest Missouri, as well as the Reproductive Health Services of PPSLR. So it certainly appears that Title 10 funds, which are not to be used to promote abortion as a method of family planning, are being sent to the Planned Parenthood facility in St. Louis. And
Mr. Baker, I'm sorry, your 2 minutes have expired.
well, thank you.
You're welcome. Be sure to fill out a witness form. Thank you for your testimony. Are there other citizen witnesses in support? You're going to lead the way. You were selected.
Thank you, members of the committee. My name is Kathleen Fork, and I am in support of these bills. And I especially wanted to bring up the fact that Columbia Planned Parenthood, in the period between 2009 and June 28th of 2012, did not adhere to a regulation by the Department of Health and Senior Services. That regulation says that if a surgical facility does not do surgery for more than 14 days, they are to be relicensed. And we observed that there would be periods of 17, 18 weeks when they were not doing the abortions, and they just continued to just go ahead and start doing them again when they were able to find a doctor who would do the abortions. The last abortion date was June 28, 2012, and finally, in December of 2013, a year and a half later, their license was no longer listed. They were no longer listed as an ambulatory surgical center after a year and a half. If we had regular inspections, this would not have occurred. Thank you.
You're most welcome. Thank you. Be sure to leave us your witness form there.
Yes, ma'am.
Any other citizens in support?
Well, I wasn't gonna say anything, but I think
Okay,
My name
Jesse,
is Donna Bernstetter, and I'm in support of the HB 190 and HB 427. Maybe this isn't comparing apples to apples, but maybe if Kermit Gosnell, is that his name, that had the House of Horrors, maybe if his facility had been inspected once in a while, then all the atrocities and tragedies and deaths would have occurred. Thank you for your questions.
all right, are there any other citizens in support? All right, oh, yes, thank you.
Yeah, my name is Mike Fork, and for the members of the committee, I'd like to say that I'm in support of both House Bill 190 and 427.
Any other citizens in support?
I'm piggybacks and I'm in support of both bills. Thank you.
Thank you.
I'm Barb Kroger, and I am in support of both bills.
Ma'am, would you repeat your name, please?
Barb Kroger.
Thank you, Barb.
My name is Jim Imhoff, and I am in support.
Thank you. Are there any other citizens in support? All right, thank you. Now we're going to move over to those citizens, folks that are not affiliated with an organization, nor do they do lobby. We don't see them in the building very often, who are in opposition. Are there citizens here that are in opposition?
My name is Tina Vanderzon. I'm from Columbia, Missouri. I'm in opposition to this bill.
Thank you.
Gordon Killian from Columbia, Missouri, and I'd like to submit written testimony.
Thank you very much.
My name is Sarah Nesbitt. I'm a student at Washington University in St. Louis, and I'm in opposition to both of those.
Thank you. Are there any other citizens in opposition? All right, I don't see any. All right, now we're ready to move into the other witnesses, which would be those of you who belong to affiliated to organizations or do lobbying here at the Capitol. In support, please. And I'll just remind you, we're doing 2 minutes.
Thank you, Madam Chair and members of the committee. For the record, Susan Klein, representing Missouri Right to Life, here to go on record in support of House Bill 190 and House Bill 427. As Representative Swan shared, this is a women's health bill. Whenever you walk into an abortion clinic, abortion is not a safe procedure. It has risks to it, and what this bill is basically doing is making sure that our state is looking into and making sure that any medical facility that a woman walks into is safe. The risks, some of the risks from abortion include infection, excessive bleeding, embolism, ripping or perforation of the uterus, anesthesia complications, convulsions, hemorrhage, cervical injury, pelvic inflammatory disease, ectopic pregnancy, future premature births and labor complications, as well as increased risk of ovarian, cervical, and even breast cancer. These are medical risks. If you're going to have this kind of medical procedure, then it is in the best interest of women's health to have an annual inspection. Obviously, there has not been consistent inspections in the past, and each time that there was an inspection, there was a required follow-up to correct what was happening. The only one that is not true about is 2014. So the history does show that there is a needed reason for these inspections to be done, and it is a women's health bill, both bills, and we strongly support both bills.
Are there questions for this witness? Thank you for your testimony. Others of you who may walk the halls and wish to testify in favor?
Thank you, Madam Chair, members of the committee. Samuel Lee with Campaign Life Missouri. I want to go on record in support of both House Bill 190 and House Bill 427. Just want to give a perspective on relative safety. Missouri right now requires that every elevator has to be inspected once a year, and requires that every school bus has to be inspected once a year. That's without exception. That's not voluntary. That's required. And looking at the national data comparing the relative safety of elevators and school buses and abortion clinics, the data shows that having an abortion in the United States is 4,667 times more likely to cause a death than if you ride on an elevator. Or if you have an abortion in the United States, it is 27 times more likely than a school child dying on a school bus. Yet in Missouri, abortion clinics are not inspected. I don't care whether you're for abortion or against abortion, or you're not sure, or whatever. Common sense would say that something which is riskier than things that we already require annual inspections should be required here in Missouri. I've included that in my written testimony, Madam Chair, and I'm happy to answer any questions.
Are there questions for this witness? Yes, Representative Runway. You may.
Could you give me a reason why anyone would be against this bill, like 190?
I can't think of a good reason. There may be ideological reasons. There may be those who don't want to have any government inspection or oversight of what they do. But other than that, when it comes down to objective health and safety standards, I don't know how any reasonable person could be opposed to one annual inspection of an abortion clinic.
Any other questions? Other witnesses in favor?
Madam Chair, members of the committee, Joe Artworth with the Missouri Family Policy Council would like to speak in support of House Bill 190. I'd like to, Madam Chair, provide a little bit of history on this issue. Nearly 30 years ago, when I was a member of this General Assembly, I sponsored the legislation that is now on the books in this state. It requires ambulatory surgical centers have to be licensed and regulated by the state. At the time, that was not the case. What happened, as you see from the statute before you, was a determination that inspections would be done as needed. However, what happened very quickly after the law passed was that a regulatory scheme was set up under which when a clinic or surgery center wanted to establish itself in operation, it had to undergo an initial survey and then be resurveyed each year. And that survey is an inspection. So while the statute does not require an inspection, the regulations do. Over the summer, along with other pro-life organizations, I had great interest in what has been happening over time on the last 14 years. No inspection was done by the state, despite the fact that regulations require it. This was not an ideological issue, I found. It didn't matter whether it was Republican or Democrat administrations, there was a failure to fulfill this requirement to the regulations. And in raising the question with department officials, I was told that those inspections had not occurred because they lacked the staffing to carry them out. Bottom line, it's my opinion that the original intention and understanding of those of us who worked to pass this law years ago should be fulfilled. And that can best be accomplished by ensuring that this requirement is actually in statute as well as in regulation, so that failure to do so is not just not completing a regulatory requirement, but breaking the law.
All right, I'm so sorry, your 2 minutes have expired.
Good afternoon. Tyler McClay, General Counsel, Registered Libraries, Missouri Catholic Conference. I want to go on record in support of both bills. I don't have really anything to add. I just want to go on record.
Others in support?
Madam Chair, members of the committee, for the record, Tabor Metzer with Missouri Family Network. A lot of excellent testimony, so in interest of the committee's time, we're simply going to go on record.
You just kind of tease me with that, taking those witness forms at the end, don't you?
I'll bring them back.
Yeah, it'd be nice if you bring that up with you when you can.
Yes, Madam Chair.
Thank you. Others in support?
My name is Michelle Lincoln with Concerned Women for America. We just want to go on record in support of 190 and 427.
Thank you. Any others in support? Seeing none, then we will move to an opposition that are affiliated with organizations in the Capitol. And I remind this side as well that we have given 2 minutes.
Thank you. Thank you very much to all the committee. I did bring my witness forms in advance. Here they are, along with my written testimony. There's not a lot of information shared. I'm going to try and do my best in the time allotted to set the record straight, but I definitely would make myself available if people have questions that I don't get to. Regarding safety, despite some of the comments that have been made, you can look at information from the CDC and see that abortion is a very safe procedure. Planned Parenthood is very committed. I'm sorry, I didn't say my name. I'm Debbie B. Testing on behalf of Planned Parenthood advocates in Missouri. Planned Parenthood is very committed to safety. We have lots of systems set up, and we can address safety daily. Our opposition to the annual mandate of inspections is that it is singling out abortion, which is a very safe procedure, for this additional restriction. If it were applying to all ambulatory surgical centers where much more complicated and higher risk procedures are being performed, that would maybe make some policy sense if there were reasons raised for the mandated annual inspection. Right now, to us, it looks like it's not health and safety motivated. It looks like it's politically motivated. And therefore, with our commitment to safety, we're going to continue providing one of the safest procedures that we can and oppose the bill. In terms of funding, the bill would direct the state to exclude the experts in family planning services, those organizations that focus in on this area of healthcare delivery. It would exclude them from receiving the funds discussed in the bill. That, to me, seems not in the best interest of the health and safety of women who are seeking, who need publicly funded contraceptive family planning care, that they would be excluded from receiving that care at the places where the expertise for providing that care is the greatest. And so that is why we oppose House Bill 427 as well.
All right, thank you. That was perfect timing. Are there questions for this witness? Representative Newman.
Hi, Madam Chair.
Yes, you may.
Good afternoon, Ms. Mead. I want to ask you some questions that were brought up actually by previous people testifying in the bill sponsor. And you actually addressed the safety. Can you tell us, particularly, we do have the one abortion provider in Missouri. We know that that's what the focus is for both of these bills. Is there an estimate of how many abortions are actually done in that facility each year?
In the 5,000 range.
Okay. But in terms of the percentage of the care that's actually offered to women, is it like the national average, or
exactly
is
99% safety record?
No, but in terms of the abortion in opposed to the other types of care that's given to women in this facility.
Oh, I see. So Planned Parenthood has 13 health centers across the state. We serve tens of thousands of women, men, and teens with a variety of services, the majority of which are preventive services. So it is less than 5% of the entire services offered by Planned Parenthood that have to do with abortion.
So again, so it's less than 5% of really the health care that's actually provided, particularly at the St. Louis facility, correct?
Correct.
I mean, the abortion is a very small, minute number in terms of the procedures that are actually done.
in terms of the scope of all the healthcare services we provide, whether that's cancer screenings, sexually transmitted infection tests, education counseling programs, all of those, yes, abortion is a very small proportion of what we do. And to clarify, Planned Parenthood in the St. Louis region has one health center that encompasses different organizations. At the basement floor, there is a Title X health center that provides preventive care and is carefully audited by the federal government and the local agencies that oversee Title X and follows all of those rules and is audited regularly. Then on the first floor, there's Reproductive Health Services of Planned Parenthood of the St. Louis region in Southwest Missouri. That is an abortion provider, again, following all the rules and regulations associated that have been mentioned with providing abortion services. And then on the top floor, there's an administrative suite of offices.
Well, and along that, the bill sponsor brought up that there's these, previous reports of unsafe facilities, previous reports of, I think she mentioned rusty equipment, out-of-date drugs. Do you know what those inspections, what that document is, where it came from?
So the Department of Health, yes, does do the inspections that were mentioned. And they did come and they threw them to prize unannounced, and they found deficiencies that were addressed immediately. And in no time were any patient safety at risk. That was made clear if you read the report. And the system worked. The deficiencies were corrected. And then there were 3 subsequent surveys, inspections, and all of those found no deficiencies. So the vast majority of the inspections that have been conducted have found no deficiencies, and there was one that did find some deficiencies that were corrected.
And those deficiencies, were they related at all to any of the surgeries that are performed there?
They were not in a direct patient safety, so nothing was administered in an unsafe way to a patient.
So, okay, just wanted to clarify that, because that was kind of thrown out there that this was in a report, but again, just to reiterate, this had nothing to do with patient care. That was the deficiencies that were found in that.
They were actually delivered to patients, and earlier when people were talking about safety, there were 2, it seemed, pieces of information that were flowing in as if they were one. The other safety piece that was mentioned were the ambulance calls to the building that are just people standing on the street basically with a little tally mark watching whether an ambulance comes to the building on that corner of Forest Park and Boyle. And no, there is no way of that person standing on the corner of the street to know why the ambulance was called, whether it was for a patient, a staff member, a member of the maintenance staff. They don't have that information. I will say that if we're talking about, and I would love for this committee to talk about medical standards and evidence-based care, the fact that patients get transferred quickly to a hospital when it is discovered that they have a condition that is beyond the level of care at our ambulatory surgical center, Planned Parenthood, the fact that they get to a hospital quickly is a high standard of care. So those transfers are evidence that the health center there gets patients, people, anyone to a higher level of care when the minute they notice that. There is no way you would want a health center to be adverse to calling an ambulance and transferring a patient, a staff member, anyone for any reason. And so that will continue to happen, I guarantee it.
So again, to reiterate, there is no document that would tell us why those ambulances were there. No. So we have no clue, as you pointed out. It could be for a large number of reasons for all kinds of medical conditions. Many that may have nothing to do with actually being there for an abortion procedure, correct?
That's possible.
So we just don't know. So again, I want to make sure that we're kind of sticking with medical science here in terms of, it's very important when we're dealing with a medical facility. In terms of do you also know what type of restrictions and medical standards and guidelines that the medical staff at the facility have to undergo?
Yes, so everyone has to be registered and licensed in the state of Missouri. In addition, Planned Parenthood, in order to use that name, undergoes a rigorous nationally recognized accreditation program where all of the safety, risk, training, manuals, every single thing that we do, including giving factual information that testifying is monitored by a national accreditation organization run through Planned Parenthood Federation of America. So those are all self-imposed additional regulations that Planned Parenthood holds as part of accreditation.
So this is not a back alley type of facility. Obviously, that there are standards that even the staff has to undergo.
Absolutely, mandatory training regularly.
And can you tell us a little bit about what organizations are actually, doing that or issuing those guidelines?
So Planned Parenthood has developed its an accreditation entity, and it's run through Planned Parenthood, and that is also associated with the insurance that Planned Parenthood carries. And so for all of those entities, these accreditation standards need to be followed. So it's a Planned Parenthood piece. And then of course in every state where Planned Parenthood is operating and when there are any sort of federal programs associated with it, we follow all of those rules as well. And no one has raised that those are in violation or that there is any risk associated with how we're operating that way.
Okay, so we're talking about already that there is medical staff at the facility, again, providing services that go way beyond an abortion procedure, and they're already under their own strict guidelines and their own evaluations, correct? And just like any other medical facility in the state, I mean, there are guidelines that they have to actually follow.
Absolutely, yeah.
So, yeah, I just wanted to point that out because we know we talk about in this committee sometimes about some other centers that provide health care for women that do not even have medical staff on board and yet might be providing some type of medical care. So if we're going to talk about, let's put more guidelines on a medical facility that's already under those guidelines, both state and federal, I think we need to do this across the board. Back to the safety, I mean, we did hear about, even though we know that this is a very small percentage of procedures that's actually done at Planned Parenthood in St. Louis in terms of the healthcare that's provided. We know that this is, I mean, we know this even around the country. Back to that allusion, that allegation that abortion is not safe. Again, I find that just a really interesting. I wanted to get some of your comments. I mean, again, we're talking about a surgical procedure that is being done by surgical experts that are overseen by their own medical organizations. And yet for us to sit here, I don't believe there's any medical staff here that's going to be testifying today. But now we're arguing about a procedure that we know is, through medical science, is safe. And now we're going to sit here in this committee and argue over that without having that medical expertise. And I just wanted you to tell us from what you know of statistics that actually again, going back to the American College of Obstetricians and Gynecologists, what are they saying? Would we be doing this if it wasn't deemed safe?
Absolutely not. Planned Parenthood adheres to the highest safety standards we possibly can, whether those are under the guidance of the Center for Disease Control, the Food and Drug Administration, the U.S. Preventive Services Task Force, and the American College of Obstetricians and Gynecologists, as you mentioned. We follow all those scientifically established guidelines, and the record is that abortion is a safe procedure, and you don't necessarily need to hear that from me. It's the Center for Disease Control, the federal agency that monitors the safety of all medical procedures in the state. They're the ones who have the record of 99% safety when it comes to abortion. And so I don't know what other facts that could be presented other than the most scientific, highest entity in the country that's monitoring these things. Abortion is an incredibly safe procedure, and Planned Parenthood is committed to providing comprehensive care beyond, obviously, abortion, which is the majority of our care, in the safest, most rigorous environment possible. And the safety record demonstrates that that is taking place.
And abortion is not always surgical, correct?
Absolutely. So there has been some discussion and litigation in the state previously about the even requirement that all abortion be conducted in an ambulatory surgical center, because there are medical, non-surgical pill form of early abortion, and those in other states aren't required to be in an ambulatory surgical center because it's not surgery, but in Missouri they are.
So we put these restrictions already on a quote surgical center that may not always be providing surgery. So again, even though that could be a procedure, we just know that that is not all of the procedures, correct?
Correct. So the legislature has definitely mandated that a non-surgical procedure be done in a surgical setting with no medical backup. That has taken place, and that's currently the law.
So I think it's just really important, particularly in this committee, for us to stick with medical science and with just medical technology here instead of coming up with the fact that, you know, abortion, relating it to kids riding on school buses. I mean, I find that offensive. And I find that just wild, just for us to just say a fact and throw it out there with no background, no source, and obviously not coming from a medical organization. I think that that's something that we need to step back a second and say, hey, wait a minute, just because I have said that the world is flat, it probably isn't, and it's probably already been determined. Last question in terms of intent. What would be, if we already know, number one, that abortion is safe, we also know that it's not always a surgical procedure. We already know that these inspections and different guidelines are actually followed, and they're mandated to be followed. What would be the purpose of these bills?
Having not authored or sponsored the bills, I can't know entirely what would be in the motivation. I will say that what it appears to me is that it's politically motivated, and I appreciate Representative Swan saying that, you know, women shouldn't be singled out for getting substandard medical care, and I think that women, where they get their care, and family planning providers should not be singled out additionally from other ambulatory surgical centers. If this is what the body believes should be the level of regulation for ambulatory surgical center, it seems to me that the body should apply it to all such entities and not single out a place where women are getting access to the full range of reproductive care. And it seems that that's appropriate too for the funding restrictions too, that why it seems political to me that we would exclude the experts in providing that care from being able to access the funds to get to the people who need publicly funded care. So it seems to me discriminatory against low-income people seeking care. It seems discriminatory against women, men, and teens who are seeking reproductive care. And I would guess that there are some political motivations behind it.
And then I guess I'm also a little bothered by the fact that we don't have.
Representative Newman,
I
heard you say you had one more question and you asked that question. And so I'm sorry, but in the interest of time, we're going to move on. Committee members, are there any other questions? Okay, Representative Hager. And I'm going to go on to say, because again, we've got a couple of committee department heads that we've asked to come today. If we could limit this to a pretty much like a 1 minute response, if at all possible. Thank you so much.
Madam Chair, you stated that statewide abortions are about 5% of the services that Planned Parenthood does. What is the percentage of this particular facility in St. Louis of abortions compared to other women's health care services, just at this one facility?
So the data I have is combined. I'm going to have to separate that out and get back to you that in the interest of time. But I've got material here that combines all the Planned Parenthood services across the state, and it's about 5. And
I just want to focus on this one facility. And I would also like to know if other services are trending up or down in this facility. And you also talked about the healthcare facility in the basement of the same building that Planned Parenthood occupies. Do they refer women to Planned Parenthood when they are receiving healthcare services from that other business?
So the health center, which is called the Central Western Health Center, that's on the basement floor, is a Title X center and follows all federal rules regarding.
Question, what do they refer to?
Referrals. Yes, I'm getting to that. They follow the federal rules, which require giving women information when they ask about it.
So they will refer their clients to Planned Parenthood if they are expressing an interest in abortion services.
So they give the woman asking, they answer her question in terms of where abortions are performed in the state, and that is at Planned Parenthood of the St. Louis Region and Reproductive Health Services.
Do you share equally in expenses for rent and things like that for
Everything
that
is
building? Or
divided out, yeah.
everything's by
It's a
square foot?
management agreement, yeah.
Thank you.
All right, other questions? Any other questions from the committee? They've done a good job. They've kind of both us. All right.
Thank you.
Thank you. So, oh, what? I'm sorry. Wait. Be decisive. You have a question. All right. You are recognized.
If, you know, if the facility is so safe and there's no problems with it, why would you have a problem with inspections? My wife is an RN. They have inspections on her hospital that she works at. And I'm just wondering why you would have a problem doing, I think you said 5,000 abortions. And I think it would, I don't see why that's a problem to have inspection.
Thank you for that question, and let me clarify. We don't have a problem with inspections. As I mentioned, we are committed to safety. We do a lot of safety measurements. We have rigorous safety standards, and in that is included getting inspected by the Department of Health as they see fit, as frequently as they see fit. We believe that the decision for inspections belongs with the Department of Health, and if this legislature has found a reason in terms of health and safety to require annual inspections, that requirement apply to all ambulatory surgical centers where much more complex and risky procedures are performed. That to us seems like the most medically motivated way to handle inspections rather than singling out the providers of one of the safest procedures.
Okay, thank you very much. Are there other witnesses in opposition? Is there anyone here for informational purposes only?
Good afternoon. I brought young Mr. Messenger as well as my own.
He's having you do his work now.
I've done his bidding more than once.
Okay.
My name is Scott Penman. I represent the Missouri Council for Family Health. We are the Title X provider of the state. And just a couple of quick observations about the second part of the bill in relation to the prioritization. We visited with the sponsor earlier today. If you look at the Title X network in the state of Missouri currently, the Planned Parenthood affiliate who shares the same offices in St. Louis is one of those providers. A large group of those folks are FQHCs. Large groups of those folks are county health departments, but then there are also another subset of folks at several community action agencies, which are then not included in the list of possible providers, kind of under the prioritization. So the FQHCs would be included, the county health departments because they're functional in the government, but then the third grouping of folks, the community action agencies that do run clinics, would be excluded under the proposal. And then there's another kind of independent group of clinics that we have, and there's a network adequacy requirement of the Title X requirements. You have to have, very similar to what we do for our health plans, you have to have enough providers across the state to appropriately deliver care, and so our network's designed somewhat on that. We are the auditing oversight organization, so in some states, the state actually does this. In Missouri, it's historically always been contracted out to an organization, and the council has been providing that service for a number of years. So we're a little concerned just about the list, depending on how things keep moving forward. And the only other thing that, since Mr. Baker mentioned, kind of adding additional components to this bill that very directly affect Title X. I think by adding Title X, it explicitly actually creates some conflict within the statute because it's not a state administered program. Then you're adding additional requirements. Depending on what those definitions are, we actually kind of create a loop where you would essentially be, it would ultimately then kind of make it impossible to contract with anyone on Title X just because of the definition what we're using around abortion or family planning services, and then provider, it kind of creates a place where you really can't even get folks in to see that provider, which most often is a nurse, public health kind of programs, or what we're talking about. So we mentioned most of that to the sponsor. I just want to kind of raise those with a couple of concerns about how that interacts with Medicaid also. And we'd be happy to answer any questions. And as things move forward and the bill evolves, we'd like to continue those discussions. We have a requirement that relates to all options counseling. That's if we're going to, as a state, provide family planning through Title X, you're required, if asked, to hand somebody a document. It says this is in our state where you can get an abortion. It's a very finite list, and that's a requirement under federal regulation. So if you don't do that, if you're not compliant, we pull all those dollars back, and lose money for breast exams and cervical exams and all the other additional services that kind of get wrapped up in this broad category of family planning. So just a few information pieces to kind of look up as you're kind of deliberating this overall concept.
All right, thank you very much. Are there any questions for this witness? All right, thank you so much.
Thank you.
Any other witnesses, informational purposes only? All right. Okay, well, that is the hearing then on House Bill 190 and 427. Oh, did you have something you want to say?
If I may, Madam Chair, just a couple of closing remarks.
Very quickly.
Thank you, ma'am. I've certainly appreciated the bit of debate and dialogue on the bill, but I would also like to point out that this bill is not an issue of high risk or safe procedures, or whether something is low risk. It's not about the number of abortions performed. It's not even about the number of and the variety and the percentage of various types of women's health care that's offered. It is about two things. One is accountability, state fiscal accountability and expenditures of dollars. Secondly, I appreciate the comment regarding we need to stick to medical science, because that's what this bill is about. It is about quality health care and about patient care. And personally, I do not need anyone to give me their medical opinion on the quality of care and what that means. Since holding a nursing license since 1970 and having taken an oath myself to provide the best quality patient care possible, I know it improper to have rusty equipment. I would not think of giving an expired drug, and I certainly would not think of retaining a single-use drug for the potential of it being used on another patient. So this is about accountability as a state, and it's about providing quality health care. And I thank you for the opportunity to present them to you today.
Thank you, and that ends the hearing completely. House Bill 190 and 427. Thank you very much. All right, we're going to do an executive session very quickly and then go to Mr. Decker. And you can come on up if you want to and be ready to go. All right. Very good. Okay, committee members, we are going to exec on House Bill 124. So I move that House Bill 124 be voted do pass. Is there any discussion? Seeing none, Secretary, please call the roll. Wait. Do I have to? Go ahead. Present, I'm here. Oh, yes. Wait. My first one.
Yes.
Brown?
Yes.
Gannon?
Yes.
Havener? Aye. Lauer?
Aye.
Meredith? Newman?
No.
Nor?
No.
Grimley?
Yes.
All right, and the vote count is 9 in favor and no, 3 noes in opposition. So House Bill 214, you have voted. I'm trying to rush through this, and I apologize. Okay. Here we go. So you have voted House Bill 124 do pass. All right, so we're going to move out of executive session. And now, welcome to the Committee on Children and Families. Please give us a little introduction, and then we probably have give us information about what you're doing, and then we'll have a few questions. Thank you.
Thank you, Chairperson Franklin, and I appreciate you inviting me to appear before the committee today. Witness form is complete. Although I have to admit, I could never remember my exact zip code for my office because I just kind of walked from the Jefferson Building, so, which is what I did today. Our hope today, and to be respectful of time, we've actually provided you with a handout that provides a lot more information than what I will actually cover. Still very readable, still something you could review in 5 or 10 minutes. I would like to know a time frame. If you could give me a time, how much time you'd like me to present. I'll try to stick to that.
20 each, is that
okay?
And you don't have to use it all?
That will be perfect. So I'm Tim Decker. I'm the director of the Children's Division. I've been in this role for about 14 and a half months now. I was previously for about 7 years the director of the Missouri Division of Youth Services. With me is Stephen Tomlinson, who's the legislative liaison for the Department of Social Services. I think many of you know him and have been around the Capitol Washington halls. What you have in front of you is a brief overview of the Children's Division, as well as what I'll spend most of my time on is talking about current trends and specific priorities of the division. We are the division of state government that manages the 24-hour child abuse and neglect hotline. When those hotline calls come in, they are classified as either an investigation or a family assessment. It's about 50-50 at this point. Investigations are allegations that could potentially be a criminal offense, and those investigations are conducted with a Children's Division child abuse investigator and typically local law enforcement. The family investigation is more of, we might get a concern about neglect or perhaps a dirty house or things like that, that we'll be going out and checking out to make sure children are properly cared for. And that's typically a process that is much more engaging of the family and trying to seek services and supports that will help that family avoid further involvement with our system. We're also fortunate in Missouri that we provide family-centered services, which are services that are directed at keeping families together and hopefully avoiding involvement with our child abuse and neglect system, at least in terms of foster care. So those are services typically provided in the home, intensive in-home services, a caseworker that might work with a family on specific issues, and so forth. And then for many of our children, we'll talk about in a minute, they unfortunately have to be brought into foster care for their protection while things are being resolved with their family or while another permanent placement, permanent loving family is located for them. So that's our foster care population. Many of our children who later get adopted are in need of post-adoption services. So we have an adoption guardianship program that provides types of supports for families that are needed so that the children can grow up and be healthy and experience the well-being that we would all want for our own children. The Children's Division also operates the state's child care subsidy program, and I won't talk much about that today, but that's certainly something that we can talk about at a later date. In terms of current trends in child welfare in the state of Missouri, if you go to page 2 of your handout, one of the things that you'll see is that the diagram at the top of the page captures our hotline activity. You'll notice since 2010, there's a trend toward increasing numbers of hotline calls where we're actually conducting an investigation and reaching a conclusion. The white section is family assessments that we completed, and the blue section is actually child abuse investigations that we co-conducted with law enforcement. And what you'll see is that the variation between assessments and investigations tends to vary, but the common trend here is increasing numbers of hotline calls that we're receiving and that we're actually investigating and including, which is important that we have citizens that are reporting these incidents of potential abuse, but also requiring a significant workforce investment to investigate those and persist to a conclusion. The second diagram is instructive in that it includes 2 different variables, and it can be a little bit confusing, but on the left side is the numbers on the left side relate to number of hotline calls. The numbers on the right side relate to the trend of a growing number of children in foster care. What that means is children that are actually ordered by a court into state custody. We are right around 13,000 children at this point. What we've seen in our trend, if we were to go back a few more years, we would find that we were at a similar level back in early 2003. We had about 12,700 children in care. And then it's a little bit cyclical in that there can be occurrences. The Donovan James case that many people are familiar with that occurred led to a period of time in the mid-2000, 2005 to 2009 where there was a substantial decrease in children in care, and we were actually at 9,100 children in 2009. And then since 2010, it's actually been growing. You'll see that hotline calls have been growing. Children in custody of the state have actually been growing as well. We think there's a number of reasons for that. This is something that I kind of wake up each morning thinking about because it's children that are not with their families. It's also takes resources, takes community involvement, takes a significant investment to make sure those children are safe and they experience permanency and well-being. A couple of things that we've identified. One that I already talked about, the cyclical nature of child abuse reporting and decisions by the courts to bring children into custody has certainly affected the trend over time. The other things that we've identified are the increasing number of hotline calls, the increasing number of incidents that we're getting related to substance abuse. So when we look at children that are actually in custody of the state, in 2010, about 16.2%, the primary causal factor was substance abuse, and that's increased in 2014 to 21.4%. Another factor that's affecting it, and if you think about the number of children in custody, it's not only entries into the system, it's also the number of how long it takes a child to reach permanency, either reunification with their family or another permanent loving family. One of the things that affects this is really a good news thing, and that we have increasingly placed children with relatives or with kinship placements. So those are, kinship would be folks that already knew the child and have an investment in that child. Relative obviously is somewhat self-explanatory. Those placements tend to be more traumatic for the child and they tend to be more stable. However, the courts often are hesitant to, they feel like the children are okay in those placements, so they often are very comfortable leaving them there, but they also want ongoing oversight by the Children's Division. So in order often to have children in those less traumatic, more stable placements, we stay involved to make sure that that's working. The increases have been substantial. In 2010, 28.3% of the children were placed in relative or kinship, and that actually in 2014 grew to 43.7%. So again, a good news thing, but that's also required more involvement of the Children's Division and more court oversight often of the situations. What we have found in terms of the entries that I mentioned earlier is that even though our numbers of children in custody have grown, our entry rate is lower than all of our bordering states except for Illinois. And Illinois has some kind of unique kind of legal and programmatic frameworks that keep a lot of children out of care. But if you compare to Arkansas and Kansas and Oklahoma and Nebraska and Iowa, our entry rate is actually lower. Our rate in care is similar to some, higher than others. So you really have to look at both entry as well as what's occurring with the children that are actually in the system. One of the other factors that we have found is that our statewide turnover in caseworkers has been a variable that affects the number of children in care. If the caseworker changes when a child is in care and we're working toward either reunification or toward a foster care or a more permanent setting, perhaps an adoption, that often gets disrupted when the caseworker changes. So we have asked the legislature last year, and certainly the governor supported a number of different initiatives we'll talk about in a minute that really invest in the child welfare workforce. If our workforce is an effective one that's implementing effective practices and is more stable, we're going to have more continuity for our children, and those are variables that tend to drive children reaching permanency, which we just described as that family more quickly. And that can be reunification in many cases. So that certainly is a variable that affects us. Also, with the increase in investigations, we often have to shift more resources to the investigative side, which often can take resources away from family-centered services and some of the other strategies that could keep children out of care. So there's a lot of different factors. It's something that's difficult to untangle. I want to talk in a minute about how we're addressing it so you understand what we're doing about it. Okay? So the next couple pages just talk about children in care and how it breaks out. So you would see that we have a fairly even number of children in family-centered services versus foster care versus adoption and guardianship subsidy. Those kind of ebb and flow over time. You also see where we have children of all age groups. So the smallest segment is the children 0 to 2, but that's a smaller age cohort. That's only 3 years, where the others are 5 or 6 years. But you can see how we have children actually of all ages. Unfortunately, some of our older children may have come into care as older children, but in other cases, they've actually been in care a long time. And we've had a difficult time reaching permanency for children. And sometimes those children are in residential care settings, for instance, or in another placement where they're just, parents aren't interested in adoption, for instance. So that's kind of how our services go. The next page really relates to childcare, and I'm not going to spend a lot of time on that. It'll kind of show the balance. We could, of course, talk about that another time if we'd like to. If you go to page 6, I want to share some of the things that we're working on. The chairperson asked me to speak to priorities of the division at this time. One has been reaccreditation. In 2010, our state was one of only 5 or 6 in the country that achieved full accreditation across the system through the Council on Accreditation. We've been for the last couple of years in a reaccreditation cycle, and we're almost complete with that cycle. So we were divided into 15 reaccreditation districts. All but 2 of those are complete, and one of those 2, it's really complete, but we're just waiting on the paperwork. So we expect sometime, perhaps in late February, early March, that we may actually receive notification of full reaccreditation, which assures that there's a baseline standard in our agency of everything from staff to child ratios to certain types of services being in place, et cetera. So we're proud of that, and it's been a very long process, and a process that our staff have invested and partners have invested a lot of time in. One of the things the legislature approved last year is a career ladder program related to our staff, and a number of the things that I'm going to talk about relate to our workforce. We simply have to strengthen the child welfare workforce if we're going to get better outcomes. Last year, beginning in July, with approval of the legislature and certainly recommendation support of the governor, we implemented for the first time in our agency a career ladder program that's actually based on specific staff performance and competencies. So if staff are with us a certain period of time and they're demonstrating certain competencies, they can actually apply to move from a children's service worker 2, which is where our career ladder used to stop, to a 3, and then later to a 4. Because what it's creating in our workforce is a number of workers who have moved to a children's service worker 3, and they're saying, what more can I do? I want to take on more responsibility. I want to become a really excellent practitioner with families. I want to get better and better. And then we have folks who aren't quite at that point, who don't meet the competency standards, who are saying, what else do I need to do? So it creates kind of an environment that's very performance oriented, and where workers can see, if I stay with the agency and I really work on getting better and better at the practice of child welfare, at the practice of social work, then I can move up in a career ladder. And guess what? I can actually continue working with families. Previously, to earn a higher salary, you had to go into supervision. And a lot of people don't want to become a supervisor. So this, if we were talking about schools, we'd be talking about keeping some of our best teachers in the classroom rather than having them move into other jobs. Because those are the positions that are really going to make a difference for those folks, and our supervisors are going to make a difference for children and families. They're the ones that are having the most contact with their children and families. So we're very proud of that. It's also creating more of a team concept in our agency. So on a team, if I'm a supervisor, I now have children's service worker 3s, now eventually have 4s that can be relied upon to mentor staff, to help coach others in best practice, to stand in for me if I'm gone, all of those kinds of things. So we're very proud of what that's kind of bringing into our workforce. And again, it's very knowledge and skill based, based on national standards for child welfare practitioners. Another thing that we're working on to strengthen our workforce is really relates to culture, change, and leadership. So we were very, very proud that we were one of only 11 sites around the country that were selected for National Child Welfare Workforce Institute grants. 2 of our universities have become partners in that, Missouri State University and the University of Missouri Kansas City. Part of That project, we subsequently applied to be designated as a workforce excellence site, and 3 of those 11 sites were actually received that designation, Missouri being one of those. So what that means is that we're not only investing in university partnerships and really restructuring how we train and develop the child welfare workforce, but we're also implementing leadership and supervisory training across the system. We have specific sites in our state that are going through a comprehensive organizational health assessment that will be developing, planning together a specific change initiatives that they will implement in their communities around improving child welfare practice and better supporting the workforce. And we're really considered one of the states that folks are watching in terms of child welfare transformation. And it's been very exciting. It doesn't obviously change the fact that child welfare is a very difficult business, and it's going to have, no matter where we get as a system, is going to have challenges every day. But it does say that we're making that combined with accreditation says we're making the very best effort to make sure that children and families in Missouri get the very best of their child welfare system. We're also implementing additional staff training, especially for investigative staff, to hone their skills in interviewing, collecting evidence, and all those things that sometimes over the years have weakened our investigative structures and sometimes led to child abuse neglect findings being overturned, some of them very justifiably so. Those rates of findings being overturned have been going down steadily because of this investment in investigative training, collecting of evidence, working with other partners like law enforcement or prosecutors and so forth. So we're creating a system where if abuse has occurred, we're going to go after it. And we're going to find out what has occurred, and we're going to try to address those problems to the very best of our ability and those of our partners to make sure that children are safe. We're also going to work on a dual track to work with families so that children can hopefully remain in their homes or in less traumatic settings with relatives and kinship. I'll go to the last page, which really have to do, last 2 pages, and I'll open up for questions, which have to do with some of our best practice things that we're working on. One of the things that kind of goes without saying, and I know some of you that have worked with the child welfare system know this, that children in the child welfare system experience higher levels of trauma than other children, and very significant trauma, often from abuse or from certain things that they've witnessed or seen. But there's also a very profound trauma that comes from separation from your primary caregivers. And even though sometimes we remove children to keep them safe, what the kids tell me, and I attend virtually every one of our state youth advisory board meetings, is that removal from their home, even though they may realize it is necessary, is very traumatic, and often leads them to actually be sad. To one of the young women on our advisory board said, you know, when I was removed from my home, I was in shock for 3 or 4 weeks. And unfortunately, the good thing, I went to a doctor and all that, but I was very quickly diagnosed as being depressed and as needing medication and other services and supports. And what I really needed was time to get over that shock, and I needed support dealing with that trauma. So we're working really hard to become a trauma-informed system. All of our staff are being trained in the National Childhood Traumatic Stress Child Welfare Toolkit. We've converted positions in every region, so we have a trauma specialist in every region. And we're working very deliberately with the Department of Mental Health to develop an intervention for separation trauma. What we want to make sure doesn't happen is we want to understand the experience of the child. We want to make sure that we're not over-responding with illness-based strategies and treatments that cause kids to feel like that there's something wrong with them as opposed to something happened to them that needs to be dealt with. So we're really trying to rewire the system in that way. And we think that over time will have a very powerful impact on the decisions that we make. So that's really important to us. Part of that is better coordination of the health and mental health care services, so that the providers that are actually seeing our children understand foster care children and feel responsible for coordinating their health care. We have a healthcare home pilot that's actually being launched in St. Louis in the next month or 2 that will seek to coordinate the healthcare and mental health care for children in foster care in the St. Louis area, regardless of their placement. So now often we all know that children in foster care, as much as we work to prevent this, can change placements frequently. Often their school changes, their healthcare provider changes, their activities that they get to participate in change, their whole life gets disrupted. We're trying to make sure that this is not one disruption that occurs, and that someone who actually knows that child is making the key decisions about their health and mental health. So we don't get into overuse of counseling, psychotropics, and those kinds of things that we might be concerned about. It might be difficult for that child to overcome in their developmental trajectory in life. So that's very important to us. The other thing that we're investing a lot of time in is kind of reworking and redeveloping our family-centered service practices. We simply have to get more effective at working with families on the front end of our system, as well as in the first 30 days of care. A lot of times the trajectory of that child's life in our system is set, either just prior to them coming or just after them coming into our system. I know Representative Meredith knows that, right? But the children you work with, and once they kind of get in the system and they're in the court system and their situation tends to be driven then by family court meetings, by court hearings and those sorts of things, we want to try to work with families to prevent them ever having to come to custody. If they do, to work very quickly toward either reunification or location of another permanent family that will be able to care for them and love them for the rest of their life. So family-centered services is really getting a lot of investment of our time because it has the potential to work with families early on and prevent children from having those traumatic experiences. The other thing, and this kind of comes on the other end of the system, these last two things, so we're very concerned about the percentage of children that come to the state's attention because of child protection issues, child abuse or neglect. And because of the issues that brought them to us, perhaps because of their experience in the system, perhaps because of just being known to the court system, perhaps because of decisions that are made along the way or not made along the way, they become involved in delinquency and eventually in the juvenile justice system. And our concern about that, even though our juvenile justice system in Missouri is actually very good, I speak very well to the Division of Youth Services and the great work that they do, that often can be one more step toward either adult corrections or actually other poor outcomes, homelessness, unemployment, instability in their adult life and other issues. So we have a very active, what we call crossover youth policy team. That's a collaboration of not only the Children's Division, but our Division of Youth Services, the Missouri Juvenile Justice Association, Supreme Court judges. Judge Breckenridge serves on the group, Department of Mental Health, where we really work to look at those kinds of issues that would lead to a child crossing over to child welfare and juvenile justice so that we can prevent that if we can. DYS would tell you that 20 to 25% of their commitments every year are former out-of-home placement kids from the Children's Division. It's a lot of kids. It's a couple hundred kids. We can do better. So we're very focused on that. And then we have a new partnership, and I can only capture a slice of what's happening here and with our initiatives. We have something called the Customer Service Partnership. It's been a great partnership of the Children's Division, the Department of Social Services, and the Division of Workforce Development that's working with the older foster youth, some of them who are no longer in care, who are not in college, and helping them actually train and prepare for jobs in the customer service industry where there's actually a career track, with companies where there's a career track. It's a really interesting partnership that's been implemented so far in St. Louis and in Springfield with St. Louis Community College and with OTC, Ozark Technical College, where we're bringing these young people in 10 or 12 at a time for 8 weeks of training and preparation at the community college, paired with mentoring and ongoing support, a direct partnership with business partners where the young people get placed in jobs and with ongoing support. So there's a group of young people that are not going to go to college, and we want to make sure that their future is a good one and that they're plugged into a career. Very great anecdotal stories from the first phase of this program. We're entering our second cohort of students at both locations in February. So we're very excited about that and the possibility for basically never giving up on the young people in our system and making sure that they don't have those poor outcomes that you hear about. So that's kind of you can kind of get our focus. It's about the kids. It's about the families right now, as well as the ongoing business of child welfare. So with that, I'd open it up to questions.
Thank you so much. I think, without a doubt, I can speak for the committee that we really appreciate the work that you do, the difficulty of the lives that you see day to day, the passion that you have. How many children come through the system in a year, or how do you apply numbers?
Yeah, so one of the numbers that we track actively is just how many children are actually in state custody, like today, for instance. And those numbers have been growing. We peaked at just over 13,000 a couple months ago. And the last month, we went down by about 54 kids. The month prior, we actually showed our first decrease in a number of years. We decreased by 1 kid. So, but you say, well, at least we're starting to level off. And that's because of those issues I shared earlier around not so much entries in the system, but time to permanency. Some increased entries, but also time to permanency. So that's the number we watched. That's the highest that we can remember in terms of numbers. So we're working actively on that.
So do you do anything to establish if they are citizens of Missouri or?
Yes. So we'll take our hotline will take a child abuse and neglect report if it occurred in Missouri, obviously. But in terms of investigating, we do look into where they actually live. So particularly in like Southwest Missouri, you might actually have a family that comes over from Arkansas for a vacation or something, or to visit relatives, and there's a child abuse and neglect reported. Depending on where that occurred, we may work with an adjoining state, for instance, on the investigation, because they may actually be the decision maker in that case. But we actually investigate any that kind of fit the definition of child abuse and neglect that come to us. We investigate regardless of where they live or citizenship status, those kinds of things. Because that's our job to be first responders, just like the police being called to a scene for crime or something like that.
And this is a large, it seems to me, multifaceted approach, a lot of things that you have to keep your hands on, your eyes on. How do you develop, what have you developed to measure your effectiveness, your outcomes, kind of establishing where we need to go, what isn't working, and how quickly can we close that gap between what we need to do and actually implementing it? Several different questions there, if you can field something in there.
Well, I think those are very good questions. In the child welfare arena, our outcomes are really driven by a number of different things. Obviously, part of that is deciding as a system and as a state what we want to prioritize. However, there's also federal benchmarks that we have to reach, and they really relate to the 3 kind of focus areas of the division. One of those being safety. So we have outcomes that we measure in terms of everything from do we complete hotline investigations on time is part of that, but also do we respond on time. So we get certain calls where if the alleged abuser has direct access to the child, where we actually have to find the child within 3 hours to verify their safety. So our workers, we're talking all times of day or night, and we're middle of the night, 3 o'clock in the morning, going out to make sure they can locate that kid and verify that they're safe. And we measure that. Did we get there in 3 hours? Did we find that child? So some of them are like the first response. It'd be like the police having response time. Did we get there in time? Did we verify safety? Did we complete that investigation properly and on time? Then down to if children actually come into care, we're looking at things like time to permanency. So what percentage of our children reach permanency within 12 months, or reunification within 12 months, or permanency within 24 months. Permanency would be if we weren't going to go to reunification track, and the court, family support team, et cetera, decided that we needed either a guardianship with a relative or perhaps the termination of parental rights and adoption. We try to have that occur within 24 months. So the idea is to either get them back with their family in a year or get them into another permanent location in 2 years. So those are things that we measure. We also measure for children that are long stayers in the system, because we never want to give up on permanency, how many of those were actually able to reach permanency, say within that next 12 to 24 months. So we really focus on permanency. Then we have well-being indicators, like we look at do kids actually get their health exams, or we look at what's happening around their schooling, all of those kinds of things that relate much more to kind of well-being type of indicators. And we probably track 15 to 20 primary indicators, so I didn't capture them all, but they're primarily focused around those things that are core to our mission and purpose as an agency. I would say one thing that relates really directly to that, and it's something I've learned coming over from the Division of Services, where in DYS we have lots of partnerships to serve kids, especially around transition and so forth, but we pretty much ran the system, right? We ran our own programs and so forth. Child welfare is much and I went around state saying it, is that the Children's Division is not the child welfare system. We're one part of it. For the system to really work, it takes the Children's Division as the executive branch agency, working together with the legislature, working with the courts, working with community partners like Representative Merritt as a CASIC, Court Appointed Special Advocates, guardian ad litems, juvenile officers, various community providers that we contract with for case management or other services, citizens that step forward to become foster parents. We're short on foster parents in the state. Those who adopt children, some who adopt very special needs children, they're very much our partners. Business and civic organizations that come through for our children to make sure that their needs are met in ways that we maybe can't meet them. So it very much takes a whole community, takes a whole state to actually get the outcomes that we're talking about. We can't just change one thing in our system and get them. We certainly have a primary responsibility for facilitating much of that. But we're really relying on many other partners to come to the table. So we try to operate in a very collaborative manner. And that's the leadership we teach, is collaborative leadership. You can't get there by yourself.
That's very good. I'm not going to take any other questions and comments in the interest of time. So if you have something, you could probably just, I'm sure you guys are on the speakerphone or something together.
I think we talked yesterday.
You know, what is that, manipulation or what?
I will say, Madam Chairperson, we did actually talk yesterday, so.
Okay, see, hold on.
Let's put you out there.
Thank you for your cooperation in that matter. Okay, thank you so much. Ms. Campbell?
Good afternoon.
Thank you for coming. Yes. Thank you so much for being here today.
You're very welcome. I'm happy to be here. I am scheduled for the appropriations hearing at 2, so I'll talk fast, and I'm happy to come back if you would like.
Okay.
My name is Alyson Campbell. I'm the director of the Family Support Division. The Family Support Division is within the Department of Social Services, and our mission is to provide programs that help to maintain and strengthen families. Oh, sure. Is that better?
Is that better, folks? Is it on?
There. Didn't have it on. Tim must talk louder than I do.
No, I actually turned it off.
Set you up for that.
So again, Alyson Campbell with Family Support Division. I'm the director. The division, Family Support, does provide services to low-income families and kids in an effort to maintain and strengthen the family relationships. I've got a handout here that provides a very brief overview of some of the programs that we administer. Food stamps, the temporary assistance for needy families, cash grant program. We do eligibility determinations for Medicaid and for child care. And the low-income home energy assistance program, which helps low-income people with heating and cooling costs for their homes. A program we administer that is not really a needs-based program is the child support program. And this is where we assist custodial parents and in establishment of paternity for kids that are born out of wedlock, and also in the establishment of orders for child support, and of course the collection of those child support obligations. On the second page, I've just shown a demographic breakout of our food stamp participants in Missouri. You can see about 43% of the individuals on food stamps in Missouri are children. And we have that broken out as well by those that are employed, adults, or adults seeking employment or in training activities, the number that are disabled, the number that are elderly, and then the remaining adults. And I think what we often forget about is that a lot of the participants that are in this program are actually children who need the food assistance. On the next page, I've given you a breakout again of the people in Missouri that are receiving the temporary assistance. That's a cash grant that is a benefit to families who have very low income, about 19% of the federal poverty level. Again, a lot of those are children, 67%. We have been noticing a decline, and a pretty steady decline, in the number of families that are receiving this cash assistance in Missouri. A couple of years ago, we were around 40,000. We're now down around 29,000 families receiving this assistance.
A lot of you may have heard about the Missouri Work Assistance Program. People who are receiving the TANF cash assistance are required to participate in work activities. Missouri had struggled in past years to meet that work percentage, but in the past 2 federal fiscal years, we have met the federally required work percentage. So we are seeing some success in that area with the families that we're working with. Just to give you a sense of, I mentioned earlier, the child support program that we administer. In the past year, we collected $684 million in child support for kids who had a parent absent from the home. We've got a declining caseload and an increase in collection. Missouri is really one of the most cost-effective child support programs in the country, and we're very proud of what we can accomplish with the money that we invest in it as a state. A couple of things, if you haven't heard, that our division also supports through TANF block grant funding, which is federal funding. We also, our budget helps to support Missouri Mentoring, the Adolescent Voids Program, domestic violence, and other support services to kids and families in Missouri. Some of the things that we have on our horizon, and actually we're living in right now, is what I would term modernization of the Family Support Division. Our technology was extremely outdated. We dealt a lot in paper records. We're trying to streamline, we're trying to modernize, and I think as a result of that, we're beginning to see good results in our program performance measures. So how long does it take me from the time we get an application to get it processed? Are our pending numbers going down? Is our backlog going down? And we're really starting to see some trends in the right direction on that. So if you all have not heard before about the Family Support Reorganization effort, you will. And if you have any questions about that, I'm more than happy to come over and visit. It is a significant change in the way that we do business in the division. And with significant change comes staff resistance, hesitation, and anxiety, customer anxiety, and challenges along the way. And we have certainly had those. We will continue to have them as we continue through the reorganization efforts. But I'm very happy to visit with any of you at any time about that. The bottom line is those efforts are designed to help better serve people more efficiently, less costly to the state of Missouri. And again, I think we're starting to see those results. So with that, I know that was very fast, but I would be happy to open it up for questions.
Okay, great. I've been informed that we have 3 minutes. There's going to be another committee in here. So does anyone have any questions? No? Well, we will have you back. We know this is budget time and you need to, be there and do that. And we'll have you back to talk a little bit more about these programs and we'll have some questions that we'll submit to you ahead of time so that, you can zero in on what it is that we're interested in visiting about. Thank you so much for your time.